Just a reminder about the master's programs that we run here at SHAR. A couple of programs that relate more closely to the session today are our MSc Diploma and Certificate in Clinical Research and our MPH Diploma in Public Health. You can download these slides by clicking on the little download icon at the top of the screen. So you should be able to see, probably somewhere above these slides, to the right hand side, a little box with an arrow pointing downwards into it. If you click on that, you can download these slides. They'll be as a PDF file, and all of these links are clickable links. So the easiest way of accessing any of these link content is to download the slides and then just click on the links from there. We do have an online event coming up where we'll be talking about our master's courses that we run here in SHAR, both our online and our campus-based programs. And again, there's a link on that slide if you want to register interest in attending that. We also run short courses here at SHAR, and these tend to be sort of 1 or 2 day courses, although they vary. We run lots of our courses online now, although a few of them are in-person ones, but the majority are run online. So upcoming ones are rapid review methods. There's only a couple of places I think left on that one now. That's running on 28th of Feb and 7th of March, so it's 2 half days in the morning. Advanced simulation methods, which is one of our biggest courses, is running from 15th to the 25th of May, and that's 6 half day sessions. How to understand statistics in research, that's 4 half day sessions running over June and July. And then systematic approaches to searching for evidence. One of our most popular courses is running on the 11th and the 18th of July over 2 half days. And finally, the SHAR Systematic Reviews and Meta-Analysis short course, 2 full days and 2 half days running from the 14th to the 22nd of November this year. Again, all those will be clickable links if you download the slides. A reminder about the SHAR Communicable Research podcast. If you're interested in SHAR's research, the Communicable Research podcast consists of episodes usually lasting between sort of 20 minutes to half an hour or so, where researchers from SHAR talk about their research in a format that's obviously designed for lay people, members of the public. So if you want to understand more about our research, even if you're not from a sort of particular research background, have a look at our podcast. Andy's put the links in the chat. And then upcoming mini masterclasses. So in terms of the next couple that are coming up in 2023, Dr. Susan Baxter will be talking about how we can involve patients and the public in literature reviews. I think that's coming up in, is that April, Andy? And then I think in March we have Michelle Black talking about best start in life, then what? So that's our next upcoming one. Again, both of those are clickable links if you download the slides if you want to book for some of our upcoming sessions. But today we have Professor Steve Goodacre talking about clinical risk prediction. I think probably many of you know quite a lot about Steve already, but for those of you who don't, Steve is a Professor of Emergency Medicine and a clinical academic at SHAR and has been for quite a while. Steve, dare I ask how many years you've been at SHAR? Andy's been here 22 and I've been here 20, so no shame in sharing.
23.
23 years, impressive. You certainly beat me and Andy. Steve is also an Emeritus NIHR Senior Investigator, Chair of the NIHR Clinical Trials Unit Standing Advisory Committee, and Senior Associate Editor of the Annals of Emergency Medicine. So just bear with me a minute while I switch over to Steve's slides, and then I'll hand over to Steve. Okay, any second now. Okay, over to you, Steve.
Great, thanks, Claire. So thank you for inviting me to give this presentation. I'm going to be talking about clinical risk prediction and asking what are we predicting and why. So clinical risk prediction is where we gather basic information about patients from their patient history, from their examination, maybe some simple tests, and then we use that information to try and predict whether they will have a particular diagnosis or whether they will develop an adverse outcome or whether they will respond to treatment. So it's quite a statistically complex area, but I'm a clinician, and so I'm going to be coming at this from the perspective of a clinician, and in particular a user of clinical risk prediction. I've done quite a lot of research in this area, most recently in COVID, also in sepsis, acute chest pain and other, obviously with my specialty, emergency conditions. We often use clinical risk prediction in emergency care quite a lot, but it can be used in all areas of medicine and healthcare. Also, I say I'm coming from this with a clinical perspective. I guess also I'm coming as a member of the public, potentially a patient, because this information can be used by, doesn't have to be used by clinicians or mediated by clinicians. It can be directly used by patients and members of the public to try and predict their probability of having a diagnosis or potential of having an adverse outcome in the future. So hopefully it's of broad general interest to people. Now, I've made it clear I'm a clinician. I'm not a statistician, so I'm not going to be going into detail of the statistical methods required in clinical risk prediction. If you are interested in that, then this is the Bible as far as statistics are concerned. And there's a huge amount of very technical and very complex statistical information that you can get into if you're interested in clinical prediction models. I won't be doing that, although at the end I will throw out a bit of a challenge to any statisticians who may be here as to how they might try and use their magnificent, clever methods to address the problem that hopefully I'm going to be able to communicate in this presentation. So, as I said, clinical risk prediction uses patient characteristics to estimate the probability of having a particular disease, developing a particular outcome, or benefiting from a particular treatment. And in today's presentation, I'm going to focus on the middle one here, the prediction of developing a particular outcome. So, as I said, we can use clinical prediction to predict whether or not a patient will have a particular diagnosis. And usually we do that if we want to decide whether or not they need investigation for that diagnosis. So we can work out if they've got a very low probability of having that diagnosis, then we don't need to investigate. If they've got a raised probability, then we need to arrange the scan or the diagnostic test. With developing a particular outcome, we're looking at predicting whether they will have an adverse event of some kind in the future. Most commonly mortality, whether they are at risk of death or other events which may be related to mortality, such as having a heart attack or a stroke or developing a cancer, something like that. The most complex one is when we try and predict whether they're benefiting from a treatment, and that's really quite complex, usually done alongside randomized trials. As I say, the particular issue that I'm interested in, and the particular area that I've done most of my work, is in predicting the probability of developing a particular outcome. So we're looking at prognostic models. A couple of examples here of the kind of things, these are a couple that we use in emergency medicine. The one on the left there is the PE severity index. So this is for people who have got a blood clot on their lung, a pulmonary embolus. It's used to predict their probability of an adverse outcome, their probability of dying or deteriorating and getting worse from their pulmonary embolus. And so as you can see, what you do is you go down, you see what age are they, what sex are they, do they have cancer, heart failure, airways disease, so a chronic obstructive lung disease, and then we've got various measurements like their heart rate, their blood pressure, respiratory rate, and their oxygen saturations, and they get points for all of them. You tot up the points, and clearly the higher number of points you have, the more points you have, the higher the risk of an adverse outcome. On the right there, you've got the San Francisco syncope rule. So this is for people who've had syncope, which is where you suddenly lose consciousness. And there's a rather simpler rule there. We just look for 5 things, which is from the patient's history, one of their blood tests, their ECG, another symptom from their history, and then their blood pressure. And from that, we can work out what their risk of developing adverse outcome over the next few weeks or months is likely to be. So hopefully you get a bit of an idea as to how we might use this to inform our clinical practice. Another one here is this is the NEWS2 score, the National Early Warning Score. Now this wasn't developed as a clinical risk prediction method, but it is often used as a clinical risk prediction method. So you can see here this is commonly used across the UK National Health Service. All our doctors, nurses, paramedics will be trained to use this, and you can see on various measurements taken on the patients, their respiratory rate, their oxygen levels, their heart rate, their blood pressure. You look at them and then you see how abnormal they are, and the more abnormal they are, the more points they get. And I think you can get up to 20 points. So hopefully most of us sitting here are all happily sitting with our NEWS2 score of 0. Maybe 1 or 2 of us have crept into the 1s or 2s, but then the more ill we get, the more our scores would go up until we were very sick if it was above 10, something like that. And again, this has been shown to predict future risk of adverse outcome. A quick aside is that you'll often see a term, an expression like this used, like the news score is a validated clinical prediction tool. And I often question, well, what do we actually mean by it being a validated clinical prediction tool? And when you look at the data behind them, what you'll often find is that it's actually been shown to have a statistically significant association with adverse outcome, which actually for me is a bit short of being validated and probably a long way short of showing it's actually useful. Because if you think about it, just simply knowing your age or the patient's age, well, age is statistically significantly associated with your risk of having an adverse outcome. The older you are, I'm afraid for an old person like me, the more likely you are to have heart attacks, strokes, cancers, and eventually die. So age is statistically significantly associated with adverse outcome. We wouldn't want to base our clinical practice on just patient's age. We'd want to have a bit more than that. So I'd always be wary about anyone who claims that a score is a validated clinical prediction tool. That may not actually mean very much. But as I said, that's a bit of an aside. There's a lot of statistical analysis you can do to tell how good a clinical prediction tool is. My question for today really is looking at, even if we've got a good, well-validated clinical prediction rule that accurately predicts someone's likelihood of having an adverse outcome, how do we actually use that in practice, and how do we use that to inform decision-making on what we're going to do with patients? And to answer that question, we really need to think about, why do we want to know the probability of an adverse outcome? And what I'll suggest is that the way we usually use this in clinical practice, and the way we usually think about why we want to know people's probability of having an adverse outcome, is because the higher the risk, the more we're going to do. The lower the risk, the less we're going to do. So if you have a high risk of an adverse outcome, if you come up the emergency department and we judge you're at high risk of an adverse outcome, we're more likely to want to admit you to hospital rather than discharge you home. We're more likely to want to investigate you. We're more likely to want to refer you to a specialist to do more things, do more tests, maybe give you more treatments. Whereas if you're at lower risk, then we're happy to let you go home. So if you came up the emergency department with chest pain and I told you that you had a 1 in 10 chance of dropping dead or having a heart attack or something nasty like that over the next week or two, then you'd probably be wanting to come into hospital and having lots of tests and investigations and seeing a specialist. Whereas if I told you your risk was 1 in 10,000, you'd probably be happy to take your chances and go off home and carry on with your life. So I think hopefully that makes sense as to how we use this information. Now, I'd suggest that this is based on an assumption that intervention is going to lower the risk of adverse outcome. And we therefore have to ask, well, what if it doesn't? What if, okay, we've identified that you're at higher risk of adverse outcome using our clinical prediction tool, but what if there's nothing we can do about that? You're stuck at a higher risk and that's it. Well, sometimes people question that. Sometimes people say, well, actually, is that my problem? Particularly in emergency medicine, we'll say, well, actually, no, my job is to work out whether you're at high risk or not. If you're at low risk, I can reassure you and let you go home. If you're at high risk, then, well, we've got to do something, haven't we? We've got to admit you to hospital. We've got to do some tests. We've got to try and treat you. So we've got to just do something rather than to worry about whether doing something will actually make any difference. And I suggest that is a slippery slope, and we need to avoid that. Because as this gentleman said, as Benjamin Franklin said, nothing is certain except death and taxes. I'm afraid I don't like to have a bit of a downer on you on this lovely Tuesday lunchtime, but everyone is going to die sometime. We are all going to get old. We're going to get diseases. We're going to have adverse events and adverse outcomes, and it's going to increase as we get older. Medical science is brilliant at keeping us alive. It's not so good at getting rid of the underlying causes, the underlying long-term conditions and diseases that we have, and it's certainly not very good at all at stopping us getting old and getting the diseases of old age. So if we just say, well, we have to do something, if we've identified people at high risk, we have to admit them and investigate them, we're going to find that we're going to get increasing numbers of people that we're investigating and admitting and doing things to without actually doing them any benefit, particularly as our populations get older and get more long-term conditions. And there are a lot of problems with that. Clearly, futile intervention is not very helpful to people. We risk iatrogenic harm if we admit people to hospital and they get hospital-acquired infections. we lie them in bed and they get dehydrated and they get blood clots. We can raise unrealistic expectations that admitting people to hospital, investigating and treatment is going to reduce their risk when maybe it isn't. Particularly with older people, people with frailty, people with social support needs, they can lose their independence when they come into hospital, lose their social support networks, and they struggle to get out of hospital. And then, of course, we've got all the problems for the healthcare system of bed blocking, access block, so people can't leave the emergency department because the wards are full, crowded emergency departments, ambulances queuing outside. A lot of these problems may be contributed to by the fact that we are simply stratifying people to high risk and then feeling we have to do something rather than thinking about whether our treatment is actually going to help people. So hopefully I've convinced you that we need clinical prediction to identify who will benefit from treatment, not just who is at risk of adverse outcome. We really want to be able to predict treatment benefit rather than just an irreversible risk of adverse outcome. So can clinical prediction rules do that? Well, I'll just briefly describe in non-statistical terms what we do in clinical risk prediction research. So first of all, we identify what are the adverse outcomes we want to predict. Mortality is nearly always in there somewhere, but depending upon the condition we're interested in, it might be heart attacks, strokes, cancer, infections, deterioration from one organ system or another. What we then do is that we then think about what are the potential predictors. Where do we have a good reason to think that clinical measurements or patient characteristics might be associated with an increased risk of the adverse outcome? Having worked out all of that, we then go and collect the data. So we might get a cohort of patients with the condition of interest. We'll measure all the potential predictors on them. We'll then measure whether they have an adverse outcome. And we'll then do statistical analysis to determine which potential predictors have the strongest independent associations with the outcome. So which, once you take other factors into account, which predictors have the strongest association with the outcome, which are the really powerful, useful predictors. We then combine those predictors into a clinically usable score or a rule of some kind to predict the outcome or estimate the probability of an adverse outcome. So really simple. The statisticians, they make an awful fuss about all of this, and I'm sure if they're given a chance they will tell you how actually it's much more difficult than all of that, and there's a lot of very complex statistical analysis that needs to be done, and indeed they're quite right. It's very easy to do this quickly and badly and do it wrong. There's a lot of statistical expertise required. But as I said, I'm not going to focus on that today. I'm going to look at what's the actual output of this, how do we use it, how should we use it. So when we start doing our research into developing a clinical prediction model, we very quickly run into a major barrier, a major problem that's been created for us for very good reasons by the World Medical Association with their Declaration of Geneva. And that is, I mean, this is a fundamental principle that hopefully all of us involved in research have not just signed up to, but we will swear an oath that we will always obey this, that the health of my patient will be my first consideration. That although in clinical prediction modelling, it would be really nice to know what happened to the patients if we just left them without treatment, because that would give us the most accurate prediction of whether the predictors are associated with outcome. I'm afraid we have to treat them. Okay, so if we realise people are at risk of an adverse outcome and we have some treatments that might reduce that risk, we really have to give them those treatments. And that does cause us a problem from a scientific point of view, because from a scientific point of view, the best way of estimating the association between a predictor and adverse outcome is to leave the patient untreated. Clearly, that is completely unethical. We can't do that. So what problem does that cause? Well, it causes something which we might call the treatment paradox. So this means that the people who are treated and avoid the adverse outcome, when we do a model, they will have no adverse outcome. And they will not be part of the group of patients who had the adverse outcome that we're trying to predict. So they'll be classified as having a zero outcome, not having the adverse outcome. So our model will not be trying to predict them. And yet they're the people that perhaps we most want to predict, because they're the people that we're going to treat, and we're going to stop them from having an adverse outcome. So that causes problems for us. It may mean that predictive performance of our model will be underestimated. It may not predict as well as it could do. Important predictors in the model may be missed. And the model may also fail to predict cases that could benefit from treatment, because if they've benefited from treatment, if they've avoided the adverse outcome, we won't be picking them up. They'll be lumped in altogether with all the other people who didn't have the adverse outcome and were never going to have the adverse outcome. So a few examples of that where this has been looked for in the literature. So this is a study recently published that looks at a score called the Q-SOFA score. The Q-SOFA is used in sepsis. Sepsis is a very nasty infection where you have infection and organ damage, high risk of death, and the Q-SOFA score has been developed to predict the risk of death and to guide treatment. These researchers evaluated Q-SOFA. They found it had a C statistic of 0.68. Now a C statistic of 0.5 is no better than tossing a coin or random chance. So a C statistic of 0.68 is really not very good. But then what they also found is that the patients with an elevated Q-SOFA score were much more likely to receive these treatments: fluid resuscitation, early antibiotics, or drugs that can squeeze your blood pressure and bring your blood pressure up. Now we assume these treatments are effective and they reduce your chances of dying. So maybe what was happening is that the patients with the higher Q-SOFA scores were getting these treatments and were avoiding dying, and that's why the prediction of Q-SOFA wasn't as good as we might hope it would be. So this is an example of how prediction from a prediction score is not as good as we might expect because of the treatment paradox. Another example, this is from the world of obstetrics. There's a condition called preeclampsia that pregnant women can get towards the later stages of their pregnancy. The hallmark of it is high blood pressure. And it can cause really nasty problems with fitting and seizures and other things like that. But there's a straightforward treatment, is that if you can deliver the baby, potentially by cesarean section, then that sorts the problem out. Now, these researchers developed a risk prediction score for predicting adverse outcome in preeclampsia. But they found that high blood pressure didn't predict the risk of adverse outcome. And they postulated that this was because the women with the high blood pressure, the obstetricians were recognizing that, using that as an indication to treat them, perform a cesarean section, get the baby delivered, treat the problem, and avoid them having an adverse outcome. So again, the treatment paradox, we're treating the people who are at high risk, stopping them having an adverse outcome, and therefore we're not then in our model able to predict it. But this is a big problem because you wouldn't want to have treatment being guided by a clinical prediction model that didn't include the one predictor, high blood pressure, that every obstetrician knows is the most important thing in preeclampsia. So we've lost one of our most useful and important predictors. Third example here, this is from COVID. So in patients with acute COVID infection, a mortality score called a 4C mortality score was developed to predict people's risk of adverse outcome, their risk of death. And the developers of this 4C mortality score found it had good prediction. They could predict people's risk of adverse outcome, and they suggested that people who are at low risk could be managed in the community. But then these correspondents to the BMJ highlighted that, well, the problem is that the 4C mortality score was developed with people who were in hospital. And they were presumably being admitted to a hospital for a reason. They were presumably being admitted for treatment. And even though we didn't have many effective treatments in the early stages of COVID-19, we did have some, and perhaps most important was oxygen. They could come into hospital and have oxygen. And so people who are at low risk, yes, they're at low risk, but maybe they're only at low risk because they were able to go into hospital, have oxygen, bring their oxygen levels up, and avoid having an adverse outcome due to low oxygen levels. Perhaps if we sent them home and they had to struggle with their low oxygen levels at home, they wouldn't have had such a good outcome. So again, we were treating and avoiding them having an adverse outcome. And so we seem to be predicting low risk when actually they weren't. So hopefully I've convinced you that this is a problem. It's a problem in terms of not being able to predict the people who would have had an adverse outcome if we hadn't treated them. But it's also a problem for the people who do have an adverse outcome. Because again, by the treatment paradox, or due to treatment effects, it might be that the people who are having an adverse outcome will have an adverse outcome whatever we do. And there are people whose adverse outcome is unavoidable and treatment is going to be futile. And we had a bit of a suggestion of this in some work that we did in COVID-19. So during the COVID-19 pandemic, during the first wave, we did some research on people coming to the emergency department with suspected COVID, and we developed a clinical prediction rule called the PRIEST COVID-19 Clinical Severity Score. PRIEST was the acronym for our study. It consists of the NEWS2 score that I've shown you earlier that measures various blood pressure, heart rate, respiratory rate, oxygen levels, things like that. And then we add on a few points for older age. We add on 1 point for being the weaker sex, being male sex, and 1 point for each level of performance status, being below unrestricted normal activity. So the more your ability to walk about and look after yourself is impaired, the higher score you get. We developed this score because it was a score that would predict the risk of adverse outcome, the risk of dying or needing life-saving intervention, which we could then use to decide which people needed admission to hospital and which people with really high scores needed to go to intensive care. So we're using it in, as I've outlined, the classic way in which we'd use a prediction score. The higher the risk, the more invasive treatment you get. However, we also did another bit of research using the same data set in which we looked at which people were most likely to get a do not attempt resuscitation order when they arrived at the hospital. So these are people who were reviewed by the medical teams, discussed with the patient their possibilities of survival if they had a cardiac arrest, and were deemed that if they had a cardiac arrest they'd be very unlikely to survive, so we wouldn't attempt resuscitation. And what we found is that the predictors of having a do not resuscitate decision made were older age, active malignancy, chronic lung disease, limited performance status, and abnormal physiological variables. So a whole load of the predictors that we also had in our clinical score. Now we have to be careful about jumping to conclusions here. Having a do not resuscitate decision doesn't mean do not treat. It's very, very different. These people will still be actively treated. But it does suggest that the variables we were using to develop a score that would push people towards having higher levels of care, more intensive care, more hospital admission, more invasive care, was actually being used in practice to identify people who would not have interventions, who might have ceilings to their treatment. Now, it's a complex situation, but clearly that suggests an inconsistency that we have to deal with. So, treatment paradox, okay, it's an interesting theory, but does it actually matter in practice? Well, I would suggest it has to, because either treatment works or it doesn't. But when you're developing your clinical prediction model, you may be assuming that intervention doesn't alter the association between predictors and outcome. But then when you're using it, you're assuming that treatment does affect. I mean, either treatment works or it doesn't. Either it's not a problem and we can just collect that, we can just develop our clinical prediction models, but in that case, we haven't got any treatments to give our patients. Or it does work, we have got treatments to give our patients, but we should be using them in the studies to develop a model and creating a treatment paradox. You can't have your cake and eat it. Either treatment does work or it doesn't. So what should we do about it? Well, I'm going to take a user's perspective here for a moment, but then I will mention, or I'll throw the floor open to any statisticians who want to tell us how they would solve the problem. I think what we need to do is we need to understand prediction. We need to answer the question I started with, which what are we trying to predict and why are we trying to predict it? And there are a few questions we can ask when we look at our clinical prediction models. So we can look at how well does the model predict intervention as opposed to outcome? How well does each predictor variable, associated with both intervention and outcome? And then does the predictor variable reflect acute illness or underlying comorbidity and frailty? So those first two questions we can address by looking at the data and by asking more of people who write the research papers in which they validate their clinical prediction models. So we can actually understand how the model is predicting outcome, but does it also predict intervention? Because we would expect that if the model is useful, it should predict both intervention and predict outcome. Whereas if it doesn't predict both, then it's more of a problem. I'm just going to go through those questions and just show you how they might work in helping us to understand prediction. So first of all, how well does the model predict intervention? So again, this is data from the PRIEST study that we did. And this is looking at the validation data from our validation of the PRIEST score. So what you can see here is these are the C statistics. As I said, a C statistic of 0.5 is pretty useless. A C statistic of 1 is perfect. Now, we developed the PRIEST COVID score to predict the composite outcome of death or organ support, major organ support, so life-saving treatment like putting someone on a ventilator or on dialysis. And we found that they had a C statistic of 0.8, which is pretty good. We're pretty pleased with that. But we then looked to see how well did it predict death for people who didn't receive life-saving intervention, so where it might have been judged that death was inevitable. And then we looked at how it predicted receiving organ support without death, so people who might have had their lives saved. And what we found, it was actually a lot better at predicting death without organ support than predicting organ support. So it may well be that our severity score is actually better at predicting unavoidable deaths than deaths that are actually prevented by life-saving intervention, which again is a concern. Now, again, we mustn't jump to conclusions here. It may be that actually we're using our life-saving treatment in the wrong patients and we're being unduly pessimistic. But there's clearly an inconsistency here between trying to predict an adverse outcome that we hope we can avoid and then the actual use of the life-saving treatments in practice. Next question is, how does each predictive variable associate with intervention and outcome? And again, we looked at this in more detail in the PRIEST study. This is from a paper that we had published in Annals of Emergency Medicine. Laura Sutton and Kieran Dash were involved in that, and Kieran did the main writing of the paper. So this is looking at the predictive variables, or 3 of the predictive variables that we have in the PRIEST score, and looking at their associations with mortality and with organ support, with life-saving intervention. And this really explains why we had much better prediction for mortality than for organ support. Because as you can see, there are 3 key variables here that have quite strong positive associations with mortality. Actually missed off the bottom of the slide, or I can't see the bottom of the slide there, but hopefully you get the gist that the older you are, much higher risk of mortality. The more limited your function is, the much higher risk of mortality, and the more unconscious you are, the higher risk of mortality. Whereas the associations for organ support are rather more complex, and in fact, if anything, if you're over 80, you've got reduced functional status or reduced conscious level, you're less likely to get organ support. So you can see there are 3 important predictive variables here that are driving our model, but yet in practice clinicians are using them in the opposite way. So whereas we expect our model that people with these characteristics have a high risk of adverse outcome are going to be referred for interventions, actually the interventions are being given in the opposite direction. So that's good. I mean, it's got implications for the kind of models we'd likely to develop. Would we be better just developing separate models for mortality and life-saving intervention? But also, if we want to use this model to predict which people should get higher levels of care, it's actually going to be pointing us in a different direction from the way high levels of care are actually being used at the moment. And then the next question, so this is where I get a bit clinical on you here. Hopefully that's okay. So this is, does the predictor reflect acute illness or underlying comorbidity and frailty? So to address this, I'm going to go back to the score I showed you earlier, the P severity index. If you remember, this is for people who've had a pulmonary embolism, a blood clot in their lungs, and it's a way of predicting their risk of deterioration or death over the next few weeks. And you get points for these various characteristics. But if you have a look through and you have to think about these, well, how are these various characteristics associated with death? Well, I think age is very obvious. Male sex, I'm not quite sure about that. Cancer, again, you're not surprised that if you've got cancer, you're more at risk of dying. If you've already got heart failure and chronic lung disease, and that would cause an increased risk of dying. But these are all things that you think, well, actually, is intensive treatment for their blood clot actually going to change their chance of dying when it's being driven by their age or having cancer or heart failure? Probably not. Probably, if they're not already having treatment for their cancer or their heart failure or their chronic lung disease, there's probably not much more we can do because hopefully they're already having good treatment for that. Whereas the lower ones down here, the increased heart rate, the lower blood pressure, the high respiratory rate, the low oxygen levels, they all indicate that this is due to the blood clot itself. And so if we admit these people to hospital and treat them, perhaps by giving them clot-busting drugs to break down the blood clot, give them oxygen, or supporting their heart and their lungs when they're acutely unwell until the blood clot breaks down, then they're the people who might benefit from treatment. So that's why I'd suggest that when we're using the PE severity index, we shouldn't just say, well, if your score is above a certain level, we have to do all these things, admit you to the hospital. If it's below, then we don't. We should use it intelligently. And actually, if you've got a high score because of your age and your comorbidities, then perhaps that's the time for an honest conversation with the patient. Whereas if your risk is due to your abnormal physiology, due to the size of your blood clot, then they're the people that we can hold out the hope of giving you treatments and making you better and improving your life expectancy. Another score, this is the heart score, and this is used for people with possible coronary syndrome, so possible blockage in the blood vessels going to the heart. People are typically coming up to hospital with chest pain. And as you can see here, there's 5 things that we measure, various aspects of the patient, and we can use it to develop a score that predicts the risk of them having a heart attack or another adverse event over the next few weeks. And again, you might think about, well, how do these things work? I must admit, this is something that inspired me to get into this in the first place, because as I was getting older, I was realizing that actually my heart score was racking up. I'd already scored 3 points before I'd even got chest pain. Now, I don't want to automatically be admitted to hospital every time I get chest pain, so that's why I wasn't too keen on the heart score. And so I had a look at it and had to think about how it might work in practice. Unfortunately, we've lost the bottom of the slide there, or at least I can't see it. Otherwise, you'd see that abnormal troponin elevation is also highlighted in red. Because if you look at the evidence, there are particular ECG changes on your heart trace, and elevation of a blood test called troponin that are very good at identifying people who will benefit from invasive treatments, from having their arteries unclogged in their heart to open up the blood supply. They're the people who will benefit from urgent emergency treatment. Whereas most of these other things are just picking up, the older you are, the more you smoke or have diabetes or high blood pressure and things like that, the more likely you are to have an adverse outcome. But there's probably not much we can do about it in terms of admitting you to hospital and giving you urgent treatment. So, I mean, you may well be advised to go and see your GP to get better control of your risk factors, or you may be advised to see a cardiologist to see whether you need investigations because you've got suspicious chest pain. But it's only those 2, the high blood test and the abnormal ECG changes, that suggest you'd benefit from being in hospital. So, well, for clinicians and for any member of the public who wants to use clinical risk prediction, these would be my messages about it. And the golden one there, the one in red at the top, is don't use clinical prediction scores to dictate clinical decision making. And you'd be surprised how often they are used. You're surprised how often you see in guidelines where it says something like, if your PESI score is above 40, you have to be admitted to hospital. If your heart score is above 4, you need to be referred to a cardiologist. We shouldn't do that. They're just not good enough for that. We need to think about what they're actually predicting. So we can use the score to predict the risk of adverse outcome, but we need to recognize this probably represents the risk of an adverse outcome with treatment. So we need to be honest and realistic about patients. We shouldn't say to them, well, if we admit you to hospital, don't worry, everything will be fine, because actually, if they're a high risk, they're a high risk. We need to break the score down and use the useful bits, and in particular, we need to think about, is the adverse outcome related to acute illness or underlying frailty and long-term conditions? Because that will determine whether they need to be admitted to hospital or whether there are other ways through their GP or through their lifestyle or anything else that we can help them. We also need to think as researchers about improving evidence. We could consider adjudicated outcomes. So this is where we get experts to look at the people who died and try and decide whether their deaths were potentially preventable or not. We can get experts to look at the people who were treated and decide whether or not their treatment avoided the adverse outcome or not. And then we can use adjudicated outcomes to indicate the people who might have benefited from treatment. We should probably be careful about composite outcomes because we may be mixing together apples and oranges, and we may get better prediction if we just focus on one particular outcome. We could report how the model predicts intervention, because if the model predicts outcome but is poor at predicting intervention, then it suggests that either we're intervening in the wrong people, or we're going to be predicting people who currently we don't usually, for whatever reason, decide to intervene in. And to look into more detail, we can look at how each predictor is associated with intervention outcome. So these are all suggestions of how we could improve when we're reviewing papers, ask for more information from the authors of those papers. I think particularly I'd like to suggest we have to be aware of black boxes with big data. So what I mean by that is where you've got these very sophisticated techniques like machine learning or AI that allow us to get very good prediction, very high statistics that look very impressive, but actually we can't unpack to see how it's doing the predicting. How is the model actually predicting the risk of adverse outcome? And if we can't do that, it's going to be very difficult to actually use the information to inform decision making. And these are becoming more common because as the availability of big data increases, as the sophistication of our statistical and mathematical techniques for analysing that data increases, we're going to see more of these clinical risk prediction models being developed using machine learning and AI. And I think we have to be a bit careful about adopting them just because they seem to show good prediction. Now, this is where I just sort of throw things over to statisticians, because there are some papers that I've seen recently that describe ways in which statistically we could adjust for treatment effects and take that into account to get better prediction. I've had a look at these. I must admit I didn't fully understand them. So if you're a statistician and you do understand them and you can explain them, the floor is now yours. I always have a bit of a suspicion about things like this, that it seems a bit like witchcraft. It seems a bit like smoke and mirrors, that somehow you could get a prediction and adjust for the treatment effects and allow you to work out what would have happened to people had they not had treatment. Surely the association between predictors and treatments and outcome is going to be very complex, interconnected, correlated, and therefore confounded. But the floor is open to the statisticians to convince us otherwise. But in summary, I'd suggest that clinical prediction models can provide useful information, but we need to understand what they are predicting. We need to understand that the adverse outcomes they're predicting are likely to be those that occur despite treatment, and we may not be predicting the adverse outcomes that were prevented by treatment. The risk estimates they generate are likely to be the treated risk, not the risk without treatment. And so all that means that when we use clinical prediction models, we need clinical judgment. So the good news for clinicians like me is that we are not, I think, about to be replaced by robots and computers. We have a few more years, maybe a decade or two, before we get replaced. And by that stage, I'm hopefully going to be safely retired. And that's the end of my presentation. So I think, Angie, you've taken over from Claire as chairing, and maybe can tell me if we've got any questions.
Thanks very much, Steve. I'm sure I can speak for everybody in saying thanks very much, Steve, indeed, for that really, really interesting discussion of the difficulties of researching and developing clinical prediction rules. We have got a few questions in the chat, a couple from Jack and one from Bennett. If anybody else has a question that you'd like to ask, do feel free to put it in the chat now, because we've got about 10 or 15 minutes for questions. So Jack has two questions, and the first is, in the treatment paradox, why isn't a treatment considered a predictor variable?
Yeah, thanks, Jack. Yes, well, that's the tricky bit, and that's what I was sort of alluding to there at the end about you could include it as a predictor variable. The difficulty that I see with that is that it is inevitably going to be correlated, I would expect to be correlated with the other predictor variables. So you may well adjust out of the model potentially useful predictor variables if you include it. And I mean, I just thought if you include treatment in your model as a predictor variable, then you will be able to predict. I mean, essentially what you'll end up with is an estimate of the effectiveness of treatment that's taken into account all the other potential confounding variables. But then I still don't see how that allows you to get an estimate of or get a good model that allows you to predict people who are most likely to benefit from treatment.
Okay, thanks, Steve. And Jack's second question was with regarding PRIEST. Do observational studies that create prediction rule risk reflect current practice and create a self-fulfilling prophecy?
Could you just repeat that? Because I think I get it.
Okay,
I just want to make sure
he's put, PRIEST, do observational studies that create prediction rule risk reflect current practice and create a self-fulfilling prophecy?
Yeah, another very interesting question. The first thing to say about that is that, yes, the tempting thing to do is I've talked about using adverse outcomes as the outcome you're looking to predict. I don't think it would do in that situation. But the tempting alternative, and we sort of did this with PRIEST because we used a composite outcome, is to use intervention as your outcome. Now, from the point of view of wanting to avoid the treatment paradox, that makes sense because you're looking to see, can you predict which people get the intervention? And then you assume the people that get the intervention were the ones that we really want to predict are the people who would have had the adverse outcome had we not given them the intervention. But you're right, there is a circularity about that what you're saying is, let's see if we can predict the people we're already treating, and having predicted the people we're already treating, then clearly we're going to just carry on treating the people we're already treating. We're not going to ask the question about whether if we treated different people, we might get different results and maybe better results. And in particular, when you look at some of the predictors in the model, it almost becomes circular that, we're going to treat people with low oxygen levels because they've got low oxygen levels. And so low oxygen levels then become a good predictive treatment, and so they get into all the models. So you're right, that is a risk. It may be a less of a risk in COVID where we're developing new interventions, but it is still a potential problem. Again, it's probably a question that in emergency medicine we can slightly sidestep, because what we're looking to do in emergency medicine, and particularly if you move that even further out into the community, if you're looking pre-hospital care, it's still quite useful for us to predict what the specialists are going to do. So if I can develop a model that predicts what the critical care team will do, then that's still pretty useful, because then I know which people the critical care team are going to intervene with. But you are right, if we use that as our way of developing future models, then we can end up just embedding the same practice and deciding that the people we need to treat are the people that we're treating already.
Okay, thanks very much, Steve. One final question, the last question that we have in the chat at the moment is from Bennett, who says, any thoughts on the use of artificial intelligence or machine learning algorithms to augment or eventually replace clinical scores? That could be a whole extra presentation, that could be another masterclass.
Yes, so I have some skepticism about AI and machine learning. First thing you've got to ask is, what are they learning from? Because any model, you need to have an outcome that you're looking to predict. And if the outcome is something that we've had to, that clinicians or humans have had to decide whether or not they've had the outcome or not, then all we're doing with AI is training the computer to hopefully at some stage be as good as the clinician. So I think that applies to things like image interpretation by radiologists. If your gold standard for image interpretation is the radiologist, then all you're ever really doing is trying to train the model to be the computer to be as good as the radiologist. In outcomes modeling, you can do it, because if you're looking to predict mortality, then clearly that's independent of any clinical judgment. But as I've implied, I think one of the purposes of this presentation is to highlight the shortcomings of just trying to predict simple outcomes like mortality, and that actually we might be better trying to predict adjudicated outcomes, which again call upon clinical judgment. And the final thing is that the way that AI and machine learning can get better prediction is by looking at more complex associations and relationships between the predictor variables. But they can be very difficult to generalize from one setting to the other. And you have to be very careful in case what they're actually doing is that they're predicting something based on the way the data was actually collected, which might be unique to a particular circumstance, a particular setting, and then it will validate very badly. So from what I've seen so far of AI and machine learning, they can get some very impressive statistics, but we're not clear what they're predicting and why. And also when we try to validate them in different settings, we often find that they don't perform very well outside the setting in which they developed. So I think we've got a long way to go, and I'm, as I say, reasonably confident that particularly as a clinician, I'm secure for the time being.
Okay, thanks very much, Steve. We've got another question from Fiona, who says, how do you balance the existence of guidelines that include risk prediction scores that appear to mandate interventions with using your own clinical acumen? And then she's also put in the current litigious environment.
Yes. How? Is the question there? I think the question there is about if you decide to overrule the guidelines, are you putting yourself at risk? Which I would hope would be, the answer would be no, because guidelines, and particularly those based on clinical prediction scores, are only guidelines. And I don't think there's anyone suggesting that we should be following clinical prediction without thinking about it and without some sort of clinical judgment. You do, of course, then need to be able to defend your clinical judgment. And if you decide to do one decision and the guidelines predicting that you ought to do another, then you'd need to be prepared what happens if you get it wrong. But this is where I see a role for shared decision making and talking to patients, because I think the litigious situation we're often worried about is that, well, I've got my clinical risk prediction score that suggests I have to admit this patient to hospital, but I can't see any benefit from them coming to hospital. Well, to me, the simple solution, but the obvious solution is to talk to the patient and explain to the patient, look, I can't guarantee that you're going to have a long and prosperous existence. I'm afraid this is what your risk is. We can admit you to hospital, but to be frank, it's probably not going to make any difference to your risk. When I've done that, I'm usually surprised at how willing patients are to accept and understand that risk. There's often a bit of a sort of prejudgment that people don't realise that we all, as I said, are going to get old and die sometime, and that we get diseases and sometimes there's nothing we can do about it, that people want to be told that everything's going to be absolutely fine. Actually, particularly older people and people who have got long-term conditions are quite realistic about that, and they only want to be admitted to hospital and have investigations if it can do any good.
Okay, and I think we've got one final question. This is from Liam, who says, is it possible to focus on people who did not get an intervention for whatever reason and solely focus on predicting mortality in this population? And then he says, well, does this go against the Geneva rule?
Yeah, I think the problem would be is that you'd have to ask why they didn't get the intervention. And my assumption would be, and it would be very interesting to look and try and see whether this assumption is true, but my assumption would be is that there's been a decision made, perhaps, hopefully, in consultation with the patient about not intervening. But there would be people who there's been a decision and a discussion that it's been decided that although they are at risk of adverse outcome, and we recognise they're at risk of adverse outcome, we are not going to intervene because we don't think intervening will be of benefit to them or have any effect. And so then you'd be looking at a population that clearly they'll have a high chance of adverse outcome. You may be able to predict it well, but they'd almost be by definition the people where you can't do anything about it. It is just worth mentioning, I mean, the model I sort of suggested that the higher the risk, the more we treat. It's not universal. There are actually one or two ceiling of treatment in rules or termination of resuscitation rules or other rules that work in the opposite direction. They actually say if you've got a high risk of adverse outcome, then actually we would recommend withdrawing intervention. So particularly, for example, if someone who's had a cardiac arrest, there are rules about if you've been trying to resuscitate them for 15 minutes and their heart is in a particular rhythm and various other things that might be measured, then that would predict actually you don't treat them. And that, to me, is a much more logical way of using clinical prediction. But they're the exception rather than the rule.
Okay, I think that is the last of the questions. Yeah, that's the last question that we had in the chat box. So, so just finally to say again, thanks very much to Steve for the masterclass today. Thank you very much to all of you who are still here, who came along, and especially to those of you that asked questions.